Morning, everyone. So we are starting the next instruction course, that is solving the jigsaw puzzle, the nuts and bolts of immunotherapy in uveitis. So I would like to, Dr. Amitabh, actually Dr. Manisha will be a little late and Dr. Reema also. So I would like to start with Dr. Amitabh. Dr. Amitabh has done his uveitis fellowship from Shankar Nethralaya, Chennai, and is presently senior consultant of uveitis and cataract services at Shankar Nethralaya, Kolkata. He is a dear friend and a great uveitis specialist. So,
good morning. Thank you, Chegitan, for that, for the invite and the introduction. And I'm at the very outset, I would like to thank the AIOC and Dr. Chegitan for this opportunity. And today I stand as a counsel for azathioprine as an immunosuppressive of choice. We know it's an antimetabolite. It inhibits the purine metabolism. And there are two enzymes which help in the metabolism of azathioprine, and that is TPMT and xanthine oxidase. And why do I say that it's a go-to immunosuppressive? Because of its effectiveness. It has a acceptable safety profile. We have a long-term experience. It has been in vogue since the 1960s when it was used for sympathetic ophthalmia, and obviously the cost. So let's see a few examples. This was a 12-year-old girl who came to me with complaints of decreased vision in her right eye. She had a sutured corneal open globe injury in the left eye, and she came with a granulomatosis uveitis in the right eye with cellularity in the anterior chamber and the vitreous cavity, disc edema, hyperemia, exudative retinal detachment, and an FAS showing disc leak, pinpoint leaks with late pooling. So this was a sympathetic ophthalmia, and she was treated with intravenous methylprednisolone, oral steroids, and azathioprine, and it resolved. You may not be lucky all the time. This was a 22-year-old male with a sympathetic ophthalmia, was on immunosuppressives, on azoran, and he still developed an inflammatory CNVM, which was taken care of with intravitreal bevacizumab. So the main indication for any immunosuppressive per se is a non-infectious uveitis like a VKH, sympathetic ophthalmia, Behçet's, serpiginous choroiditis, and so on. This is one of my patients who had a granulomatosis uveitis, and you can see multiple pockets of SRF with fibrin septae, disc leak, pinpoint leaks with pooling. So this was a VKH, and it was treated with IVMP, steroids, and azathioprine. And you can see the resolution of the subretinal fluid following treatment. And this is a 6-month follow-up with a 612 N8 vision and a 624 N18 vision. Obviously, did develop some subretinal fibrosis. Another VKH, an active stage, and with IVMP, steroids, and azoran, he's resolving now. This was a 24-year-old lady with a decreased vision in the left eye, had a macular GHPC, and this is the resolved stage. She was also treated with intravenous methylprednisolone to start with, followed by oral steroids and azathioprine. A 29-year-old male with decreased vision and floaters, and we see there's an active retinal vasculitis in both the eyes, and with steroids and azathioprine is resolving. So other than the intraocular inflammation, corneal graft rejection is another indication of azathioprine. So most of the studies have shown a good effect of azathioprine following therapy, excepting just one study which was in the 1960s, which said that it is not effective. It has also been used for JIA-associated chronic anterior uveitis, either as a monotherapy or in combination with other immunosuppressives. And it was in vogue for Behçet's disease in the earlier stages, where it was shown to control the progression of the disease. So this is one of my patients, a 48-year-old male with retinal vasculitis, HLA-B51 positive or Behçet's, treated with steroids and azathioprine. It can also be used in special situations like pregnancy. So there is a case report of the use of azathioprine in the first trimester of pregnancy in a VKH. But to note here is if azathioprine is used with steroids, the chances of teratogenicity go up. It can be used as a steroid sparing agent or as a steroid equivalent as in VKH and SO. And it has helped us in reducing the maintenance corticosteroid dose from around 25 to 60 milligrams per day before initiation of azathioprine to around 5 to 10 milligrams per day in 6 months' time, with a 88% reduction in steroids at 6 months, an improvement in vision in 81%, and an improved inflammation score in 92% of the patient. It also helps in induction and maintenance of remission, with a 90% remission within 1 to 6 months, and 88% of the patients did not have any recurrence during a follow-up of 1 year. Can be used alone or in combination, and there are various reports of triple-agent immunosuppression in serpiginous choroiditis and VKH. So a couple of pre-initiation checks before we start the patient on azathioprine. There has to be an absence of infection. You need to take baseline counts and liver function test, TPMT levels, liaise with your internist, and dose according to the body weight. So TPMT actually inactivates the toxic product of azathioprine. Therefore, a patient who has a TPMT deficiency, the chances of side effects would be much more. So if the levels are less than 5 units, it is contraindicated. Whether if it is more than 19 units, it can be given in a normal dose. The dosage being around 1 to 3 milligram per kg per day. The most effective dose being 2 milligram per kg per day, and the expected duration of onset is around 1 to 3 months. It has also been used in lower doses as a steroid-sparing agent in VKH. So in this modern day of medical litigation, it is of utmost importance to take a written informed consent, and this is one of the consents which we have at our center. It does interact with other medications like allopurinol, causes severe leukopenia with ACE inhibitors, and can also inhibit the anticoagulant effect of warfarin. The side effects, common ones, are nausea, vomiting, diarrhea, the other ones being bone marrow suppression and hepatotoxicity. Fortunately, these are reversible. So this was a 27-year-old male with retinal vasculitis treated with steroids and was on azathioprine when his liver functions got deranged and we had to withhold azathioprine. Some anecdotal side effects of a disseminated tubercular granuloma, pancytopenia, severe cholestasis, alopecia totalis, and knuckle pad hyperpigmentation. They are clinical indicators of potential fatal complication because of pancytopenia secondary to azathioprine. Can cause infections like herpes or recurrent aseptic meningitis. As far as the risk of cancer is concerned, there are various studies which show that there's no significant increase in the risk of death or death from cancer if it is used for intraocular inflammation. The indications for withdrawal are a total count less than 3,500, platelets going below 1 lakh, hemoglobin less than 7 gram, and the liver enzymes getting deranged. If we compare it with other immunosuppressives, its side effects are almost similar to that of methotrexate. Mycophenolate might score over azathioprine as far as its side effect profile is concerned and the treatment success, but obviously one of the deterrents is a cost. When would we substitute azathioprine if there's an intolerance or if there's an inadequate response to treatment in 3 months? And there's a 100% consensus in conditions like Behçet's, sarcoid, sympathetic ophthalmia, GHPC, and retinal vasculitis. The cost used to be much more in the earlier days, around 1,000 rupees per month, vis-a-vis mycophenolate mofetil, which used to be around 8,000. But that gap has been bridged now, and there are cheaper brands which are available. So this would be somewhere around 500 rupees a month of azathioprine as compared to mycophenolate, 3,600. So azathioprine is still, could be the drug of choice, though in the earlier days that this was the only immunosuppressive available other than methotrexate. But nowadays, there are other immunosuppressives like mycophenolate available, and Dr. Chekitan would be covering methotrexate. And I thank you for a patient hearing.
It's a wonderful presentation. I'd just like to know, is there any retrospective or prospective comparative study between azathioprine with methotrexate or azathioprine with mycophenolate mofetil?
Not really. So with methotrexate and mycophenolate, there is. But azathioprine has not had, there's no head-to-head trial.
Yeah. And did you yourself have come across pancytopenia in your treatment?
No.
How often it?
Yes, but we have been very vigilant with the blood counts. So I get it done every month. And the moment there's an increase in, there's either a leukopenia or the platelet counts going down, we become very careful with the use of azathioprine, either reduce the dose or switch over to some other immunosuppressive. But I never have had a severe pancytopenia with azathioprine.
And do you do the TPMT anytime?
I had one patient who had a TPMT done, but I didn't do it. He had an Ehlers-Danlos, he had a Erdheim-Chester disease, and since his TPMT was, he was deficient, he was put on sirolimus. But TPMT is costly, it costs around 4,000 to 5,000. Yeah. But I think a prudent approach is to have a step-up approach to start with a lower dose, monitor the counts, and then increase the dose of the medication if the patient tolerates it.
Thank you.
What
Any
are your
question from the audience?
what are your cutoffs, Amitabh, in blood counts? You know, when you say when you should stop it or
Yeah,
change
so
it.
if the total counts go down below 3,000 per millimeter cube, or the platelets going down below 1 lakh, or your liver enzymes becoming twice or more the baseline, that's when we would either reduce the dose. And if it goes up too high, say 4 to 5 times the liver enzymes, then probably we'd need to stop the medication and switch over to something else.
And also the tapering, I wanted to ask you, like if we have given 150 milligram, for a month, and then we slowly taper, and then 50 for maybe months together. So the big question is, when do you stop? That is the thing. And do you continue some patients only on azathioprine, or there is always a small dose of steroid? Because I usually, when I'm giving methotrexate, there's always a 2.5 milligram or a 5 mg steroid which is going on, and somehow I don't feel confident. Even if I go to 2.5 milligram alternate day, I don't feel like stopping it. And studies have proven that, the uveitis recurs if you keep it like only on methotrexate. So what's your take?
I think the dictum is to hit them early and hit them hard. So you start, if the patient is tolerating the medication, then you start at a full dose. The main aim of starting immunosuppressives is to try and either wean the patient off steroids altogether or to come to a minimal dose. In many of these patients, like a VKH, which is bound to be recurrent on SO, you may need to continue the immunosuppressives for a very long period. But I've had patients where I have totally stopped steroids and continued them on azathioprine for longer periods of time, say a couple of years in some of these patients. But
that would be 50 milligram? Or?
Yeah, some of them have been on 25 milligrams per day. There's no rule of thumb of when to stop. Yes. You don't really know which is the end point of treatment. I think it's just trial and see how things go.
Most of the people feel that after 2 years, there's cessation of that disease. We can rather be safe in stopping the azathioprine.
Thank you so much, Amitabh. Sir, would you like to present next?
Whatever it is.
Partho, whatever you say.
Partho.
Dr. Partho, you are next. So since some of the speakers are not around, so they are just in other lectures, I would request Dr. Partho to please present his talk on JAK inhibitors, taking on the challenges. He's a senior consultant and professor in the Department of Uvea at Shankar Nethralaya, delivered more than 240 plus talks and has published more than 150 research articles. He has held esteemed editorial positions and authored over 70 chapters in 4 books. He is also the founder cum chief editor of popular ophthalmology portal, eophtha.com. Dr. Majumdar has been ranked among the world's top 2% scientists in 2024, according to scientists list by Stanford University. Welcome, Dr. Partho.
Thank you. Thank you, Chekitan, for having me here in this wonderful instruction course. So I'll be talking on JAK inhibitors. So just continuing the discussion, I think I was enjoying the discussion. Excellent talk by Amitabh Kumar, sir. So I think two important things for the azathioprine is that it's not a drug if you want to prescribe an immunosuppressive in your private practice and want to sleep peacefully at night. Because if you are in private practice and you want to use azathioprine, it's always better to do a TPMT. We have come across some severe complications of azathioprine like alopecia totalis, where the patient typically complains of the hair comes up like a wig. The entire hair will come and the patient will call you, it happened within 20 to 24 hours. So there will be total baldness within 24 hours or less than that. So that indicates if your patient is telling you that I have all hairs are coming out, tell the patient that immediately you consult a internist, because it indicates severe bone marrow suppression and the pancytopenia. So I think this is a very important when you are doing azathioprine. And a second thing is that it can happen to anyone, the LFT plus this thing. Only good thing about the azathioprine is that it is safe in pregnancy. So now all the rheumatologists and everyone have started believing, and we have a lot of data to show that the azathioprine can be used safely in pregnancy. So I'll just move from azathioprine, we'll go directly to the JAK inhibitors. I think it's a little higher immunosuppressive. I don't have any financial interest. Now coming to, if you see that how we work, we UVA specialists, we try to actually suppress our immune system. And when we try to do that, we have corticosteroid, we have immunosuppressive, and we have biological, which also includes JAK inhibitor. Now what happens with corticosteroid? When we use corticosteroid, the aim of the corticosteroid will be to move the lymphocytes from the extravascular space to the intravascular space, so that there is total immunosuppression. And as we know, the corticosteroids has a lot of systemic potential side effect. Then we have immunosuppressive, where each immunosuppressive is actually determined to destroy the inflammatory cells. Like sometimes we interfere with their metabolism. We call them anti-metabolite, like methotrexate, mycophenolate and all. And that's how we kill those T lymphocyte cells, so that there is immune suppression. Now we have cytotoxic agents where the drugs like cyclophosphamide are actually made to actually kill the inflammatory cells, the macrophages and all, and that's how they affect our other body cells also. So there will be a severe immunosuppressions. The third generation, the biological, are much higher order. So what they try to do, they actually tend to block the pathways of the cytokine mechanism. For example, you have TNF alpha, which is a very potent cytokine. So these drugs are only to act on that pathway. So that's how actually it starts. Now, how the blocking JAK-STAT pathway helps. I am not going into the JAK-STAT pathway detail, but you have to understand that the maximum inflammatory cytokine, mostly the interleukin 2 and 6, they actually known to utilize this JAK signaling pathway. So the aim of the therapy is to prevent those JAK-STAT pathways, so that we can suppress the interleukin 2 and interleukin 6. So what happens here, the cytokine binds to the specific receptor on the cell surface, and following that there will be activation of the receptor associated Janus kinase. So that's why we try to use this drug to prevent that pathway, so that there is a immunosuppression. Now, there are a lot of immunosuppressions are available in India. JAK inhibitors are available in India. Tofacitinib and baricitinib is also there. But baricitinib and other drugs we are not using because they are very expensive. So the entire discussion will be actually based on the tofacitinib, which is now FDA approved for the rheumatoid arthritis and psoriatic arthritis, ankylosing spondylitis. Remember, tofacitinib has not been yet actually FDA approved for the ocular use. Now, our experience started when we used the first JAK inhibitor, the tofacitinib, in a case of recalcitrant scleritis with JV sir. And that was the first case report from India. Then following that, we published a lot of articles, tofacitinib in Vogt. Then we have a series of original articles on refractory cases of uveitis, scleritis, and tofacitinib in scleritis we have published. And recently, just now, it is accepted for publication. We have actually written an extensive review on JAK-STAT inhibitors in non-infectious uveitis, which will be coming in next edition of IGO. Now, what are the advantages of tofacitinib and why tofacitinib can be used? Number one, tofacitinib is a small molecule, more likely to cross blood-retinal barrier. This is more theoretical. But if you use this drug in like exudative retinal detachment or in any posterior segment, non-infectious uveitis, there are chances that this drug actually can act better because of its smaller size. Now, it has an added advantage over the TNF inhibitors because you can give it as a tablet. So all the TNF inhibitors, you have to inject them in subcutaneous route, whereas the tofacitinib you can use in oral route. And also, if you look at the dermatology in other subspecialty, they have started using this JAK inhibitors in a topical form. So the days are not far when the tofacitinib and other things can be available in topical forms also. Now, tofacitinib, another characteristic is that it has a very rapid absorption and elimination. So peak concentration reaches 0.5 to 1 hour, and it has a half-life of 3 hours. So it stays less in the body and acts really fast. So these are the advantages of tofacitinib. Now let's come to the second point I want to highlight, the cost of the treatment of tofacitinib. Now a 9-year-old boy with chronic anterior uveitis diagnosed with juvenile idiopathic arthritis, and there is significant joint involvement. Now the patient was sent to pediatric rheumatologist. The first choice of the drug here is that adalimumab with methotrexate. Now if you see, even with the biosimilar, the cost of per injection with adalimumab is 6,000 to 12,000. So this is sometimes not possible for normal Indian patients who does not have any insurance cover. So in that scenario, the tofacitinib and methotrexate can be a game changer. Why? If you look at the cost of the therapy, the adalimumab, the lowest, if you are purchasing from directly from the company, then it comes around 6,000, but in MRP rates are always higher, like 12,000 and more. But here you see the tofacitinib is per tablet cost around 20 rupees. So per month therapy is 1,200. So that's why I keep telling all that it's a poor man's biological. You can actually use that. Number 3 point is that role in treatment-resistant cases. This drug actually can really work well if you use in some certain cases. Like this is a case of 13-year-old boy, recurrent posterior scleritis who did not respond to oral steroid and methotrexate. Then we shifted to both methotrexate and mycophenolate. Still he had recurrence. And finally, the tofacitinib with tofacitinib, we can achieve the remission. Now this is another, you see that a 50-year-old nodular scleritis, the steroid, mycophenolate and methotrexate was not effective, and finally the tofacitinib actually helped to attain the remission. Similarly, this another patient, 40-year-old male, diffuse anterior scleritis, steroid and azathioprine was started, and there was a severe rise in the liver enzymes. So finally we shifted the patient to tofacitinib, and it really worked well. I'll show you another case, a 50-year-old male with diminution of vision. You can see he attended another hospital because of the sympathetic ophthalmia, where they treated and told that it cannot be done because it's almost lost guarded visual prognosis. This patient came to us with complicated cataract, and you can see the slit lamp photograph. And this was the, you can see the bullous RD, you can see the configuration well in ultrasound also. And this patient we treated with IVMP, oral corticosteroid and tofacitinib, and it responded really well. We actually further went ahead and did the phacoemulsification with IOL implantation, and you see the response here from counting finger, it actually increased to 6/12. So now if you see that what are the cautions you have to take, that you have to understand that this drug can be used with caution in elderly individuals. There are chances of venous thrombosis and the cardiovascular risk, because this drug can actually affect the system. This is another case report we published, though we don't want to contribute, but we thought that we must tell the world that this can happen in elderly patient. This patient was a known patient of hypertension and rheumatoid arthritis and non-necrotizing scleritis, not responding to steroid. We used tofacitinib, and after I think 2 months later, the patient developed superiotemporal BRVO. Now you can argue that it can be due to the primary existing hypertension and other risk factor also, but we decided that at least because thromboembolic side effects are common with tofacitinib, so we must publish this case report so that we can tell that there may be chances of that which you should not overlook. So the drug should be used with caution in elderly. Now, just last point I'll highlight that the risk of infection is very common. This is a 41-year-old lady and developed herpetic stromal keratitis at the periphery after the use of tofacitinib. So the viral infection is known to be a very common factor or common risk for use with the tofacitinib. And here you see there is a wonderful lady who presented with scleritis, and there was a history of tuberculous related cervical lymphadenopathy. Tofacitinib was used for 5 months, but there was no recurrence or reactivation of tuberculosis. It has been claimed that the tofacitinib, the risk of TB, which is much higher with the TNF alpha blocker, is less with tofacitinib. So this can be a very good point in country like India to use this drug. Now, but you have to understand, I told you the viral infection is common and you have to tell your patients for that. This is another patient who developed herpes labialis after 1 month of tofacitinib use. But you have to understand that these viral infections are very mild in nature. This patient, the tofacitinib was stopped and she was started on oral valacyclovir. In view of persistent scleritis, we continued the tofacitinib. That's all. Thank you.
Thank you, Dr. Partho, sir.
I just want to ask you that have you used the tofacitinib in some conditions like vision-threatening uveitis like Behçet's disease, serpiginous choroiditis?
Serpiginous, if it is autoimmune, I think one can use. Behçet disease, I'll be little reluctant because we should treat the Behçet disease very aggressively. And Behçet disease, I think it's better to, if the patient can afford, I'll just prefer to treat them with biological.
Also, Dr. Partho, can you please elaborate on how you, what are the investigations that you would do before you start tofacitinib, which you add? What are the investigations which you would like to keep on doing? You know, like for azathioprine and methotrexate, there's a fixed timing. You know, you do it in 2 months or 1 month.
Yeah.
And what would be the starting dose of tofacitinib? How long can you continue and how do you taper? And what would be the main indications in short?
It's a very good question. So tofacitinib, if you read the literature of all side effects or the effect, no, it has been typically associated tofacitinib used 10 mg twice a day. But tofacitinib in our setting, we use it as a 5 mg twice a day. So the side effects are much less. Unlike biological where we need to do MON2 and other tests before starting, tofacitinib actually does not require any pre-test to start the drug. Only one thing I feel in any pharmacotherapy, if you are doing, always try to do a baseline liver function test. Because any drug can cause rise of liver enzymes, and you need to have a baseline comparison to show that whether the effect is due to drug or due to some other things. So I think LFT you must do, routine blood count you do, though it does not have any implication with tofacitinib. Coming to azathioprine and methotrexate, I always try to do the baseline investigation like blood count and liver function test. It's also important to check for this hepatitis B and C markers. These are very important, which we often overlook. I think it's always better to do this marker before you start the immunosuppressant.
I've got a last question. So I want to ask you, like a HLA-B27 positive anti-uveitis having multiple recurrences, can you give, to prevent recurrences, we give methotrexate, can you give tofacitinib?
I won't prefer, sir. HLA-B27 associated uveitis with recurrent attack, I'll try to treat with oral methotrexate. Because that will be my common drug. Tofacitinib I will use only if it is not responding to other drug. It's never a first line drug to be used. I think we should not treat all patients with tofacitinib. It should be reserved for certain cases where it's not working to other medications.
Yeah, what would be your main indications in a short?
Tofacitinib, as I showed, I will use if it is not responding to one immunosuppressive or two immunosuppressive. It's sometimes the biologicals are indicated, but the patient can't actually afford biological therapy. These are the cases I think we can try tofacitinib.
How's been your experience in intermediate uveitis or pars planitis? Have you ever used in that?
It's good actually. It's a good drug. It can means help you to achieve a good remission of the drug. But yeah, in acute cases, severe cases, I think as I always prefer that you have to use the corticosteroid to.
Like suppose we are giving oral steroids, can we start tofacitinib, or should we give oral steroid methotrexate and then go to that? I mean, how should we go?
Yeah, usually that's the standard. Like you use methotrexate and then
as a third this thing.
Yeah, I have a question. Excellent talk, Partho and Amitabh's talk. Now you see why tofacitinib is used in ulcerative colitis. That's a very because no tofacitinib is given orally, and you see ulcerative colitis, which involves the gut. Do tofacitinib have effect on the microbiome? Okay, there are protective and beneficial microbiome. There are what you call harmful microbiomes. Okay. Now, if the harmful microbiome get killed, does not matter. But if the protective microbiome get killed, then it is a problem. And now you are telling that it can come as a ocular drops. Okay. Now, what is the effect of those tofacitinibs for the local as well as GIT microbiome?
I think the treatment in ulcerative colitis is totally different. It does not have any oral or anything, because main thing is to prevent the inflammation of that particular GI tract area, and that is inflammation based. I can tell you about the immunosuppressive effect of any drug, but I am not the right person to ask about the gut microbiome. I'm sure that many of us, we are just learning to understand that about the gut microbiome. So I have no idea about how tofacitinib is actually affecting the gut microbiome here. I don't have data also to discuss that. Regarding the ocular topical use of tofacitinib, because if you look at the our dermatology colleague, they are the first have started the JAK inhibitor as a topical form. They have all kinds of hair lotion and everything of tofacitinib, and there are actually many ophthalmological companies are actually investing now to bring this to various JAK inhibitor in topical form to treat the anterior segment inflammation. Few rabbit model studies have shown that the topical application of JAK-STAT inhibitor penetrates much more into the posterior segment than the corticosteroid. So we are hopeful that something may come. These are my assumption based on the existing literature, but that's it.
Sir, I have two questions.
Yes, madam.
That was a very nice talk, sir. It was an eye-opener for us. Sir, once we have start corticosteroids, then corticosteroid with methotrexate, how long we wait for each medicine to assume that it has failed and then go for the next medicine? Like I have a patient with scleritis. I'm not a uveitic person. With the long-standing anterior scleritis, not responding, now she has got a nice scleral thinning. It shows as though she's going to go into staphyloма formation. And now we started her on methotrexate. How long should we wait for it to, because she's again and again still having attacks?
Thank you, ma'am. It's, I think, very important question. I'll try to answer your question in two parts. The number one, you asked that how long we should wait to understand the efficacy of a drug. That will be with a drug like methotrexate and mycophenolate. These drugs actually takes a lot of time to achieve the desired level of serum concentration. So methotrexate and mycophenolate, it's ideal. It takes actually almost 1.5 months to achieve the desired level concentration. So if you want to tell some patient as a treatment failure with this immunosuppressive, I think it's better to wait at least 3 months. 3 months of therapy, then you can actually decide of changing your immunosuppression. Coming to the part 2 question, you told that you are dealing with a scleritis patient which is having a scleral thinning and staphyloma formation. I often feel that often in ophthalmology, we are taught that you go in a phase manner. Like you first try this, then this, and then you go to the final step. Like biologicals, many of the time we are afraid that you should not be used first line therapy. Even I believe in that. But conditions where the ocular integrity is in threat, for example, a patient of necrotizing scleritis showing thinning, this is not the ideal case experimenting and going phase-wise manner. These are the conditions you have to directly go for the aggressive therapy. So these are the conditions I will recommend you you send the patient to rheumatologist, evaluate and start some biologic. Because you can't wait for why the methotrexate or mycophenolate is waiting or not. Because 3 month time for a necrotizing scleritis with scleral thinning and staphyloma formation can be dangerous.
So you're treating yourself, sir, or you're sending all the patients to rheumatologists?
Biological, yes, we are sending. That's what my the main aim was, that we are sending for all the patients to rheumatologists for the biological therapy. The JAK-STAT inhibitor, because it is available orally, maybe a time will come when the ophthalmology will start prescribing the drug, just like we prescribe methotrexate and mycophenolate.
Thank you.
Partha, you can't leave so early. Just last question. Do you take any special precaution as far as the antibiotic prophylaxis is concerned if a patient is on tofacitinib and is undergoing a cataract surgery?
I don't take.
Nothing.
Don't take.
Okay.
Thank you so much, Partho. A lot of discussion. And now I invite Dr. Manisha Agarwal to please share her thoughts on when and how to start steroids in uveitis. She is the Director of Vitreoretina and Clinical Research at Dr. Shroff Charity Eye Hospital, New Delhi. She's done a Vitreoretina Fellowship from Shankar Netralaya, has 150 peer-reviewed publications and 7 book chapters to her credit. She is Secretary of the Vitreoretinal Society of India. She has achieved many awards like the Indian Society of Prevention of Blindness Endowment Award, Best Lady Fellow Award and Vitreoretina Fellowship, Spirit of Humanity Award, Best DOS Papers, and Dr. A.C. Agarwal Trophy and Narsingh Rao Awards for 2 consecutive years in AIOC in the uveitis category, and Best Poster Award in IUSG. May I welcome Dr. Manisha to present her talk.
Good morning, everyone, and thank you, Chekitan, for making me a part of this wonderful IC. I think we can't really talk of uveitis without touching upon the use of steroids in patients of uveitis. So it's very rightly said that no one is allowed to die or go blind without a trial of steroids. The goals of treatment with steroids, once you've ruled out infection or malignancy, ocular inflammation is the principal cause of complications in most of the patients. And the control of inflammation is the primary goal, and we have to firefight to control ocular inflammation. The other goals, of course, being secondary, like early control of inflammation with minimal side effects, prevent damage to ocular structures, and also prevent long-term visual loss. The modalities of treatment is systemic steroids and, of course, local steroids, such as a posterior subtenon tricot injection or a longest acting Ozurdex implant. And, of course, recently we have also started talking of the suprachoroidal triamcinolone depot. The systemic steroid therapy in uveitis is divided into 2 phases. One is the induction phase and one is the suppression phase. The induction phase is the initial phase of the control of the active inflammation, and it's very important because if you don't give the steroid therapy on time, then it's very difficult to control the active phase of inflammation. It's applicable to all cases of inflammation, and we have to do it as quickly as possible and in full dosage. I think that's very important. You often get patients who would be on something like a 0.5 milligram per kg body weight of steroid. That's really not going to serve the purpose. The maintenance dose of control of inflammation in chronic inflammatory diseases is to be considered, especially after successful induction phase, and also for chronic severe diseases where the long-term suppressive therapy is the key to the long-term success and good outcomes. So what are the indications when you like to use systemic steroids? One would be a chronic bilateral disease, which is beyond the anterior segment, where you would just not think of anything but systemic steroids. Those patients who are resistant to local therapy, the eye diseases associated with some form of systemic disease, and severe inflammation that is too painful or destructive to the patient. We are all very well aware of how we go about starting the steroids and how do we gradually taper them. Monitoring, of course, the systemic parameters such as the blood pressure, the glucose levels, the lipid profile, the bone density, and therefore it's very important to keep in mind the supplemental therapy when we are giving our patients long-term steroids. Now, oral corticosteroids in children, we have to remember the short-term oral steroids are acceptable but not long-term because they are going to be having an impact on their growth. Early use of immunosuppression is indicated in children. The growth monitoring is very crucial if we are contemplating a long-term steroid therapy, and mostly such therapy would require a joining of hands with the pediatrician or with the rheumatologist. Now, this is one of our patients, a 61-year-old female patient complaining of pain and floaters in the right eye for last 3 days, having a vision of 6/9 N8, and she has a yellowish mass lesion in the supranasal quadrant with an exudative retinal detachment. And she was maintaining a good vision because the macula was just starting to get involved. And she also showed dilated conjunctival vessels over this area. We, of course, did a fundus fluorescein angiography, which was not very informative. And we also did an OCT, which showed the exudative detachment, and there was a kind of a bumpy choroid that we were dealing with. So this is the B scan of the patient, which again is suggestive of the exudative RD, and you see that the retinochoroidal thickening is very significant in this patient. And this is the FFA picture where you have a hot disc. Apparently, this patient was referred to me by the oculoplasty department as a lymphoma of the choroid. And we suspected that she probably was having some kind of an inflammatory pathology. So you do find a hot disk, which very much goes in favor of an inflammatory pathology. You have these pinpoint leaks. You have a diffuse leakage in the area of the supranasal quadrant. So a presumptive diagnosis of a nodular posterior scleritis with exudative RD was made. All investigations were done to rule out any infectious pathology. And the patient was started on oral corticosteroids. And in a short time of 2 weeks, the patient started very beautifully responding to the oral steroids, and you see that the inflammation is quite under control and the mass lesion has also settled down. So you have to rule out a masquerade, you have to rule out an infection, and if you are convinced that it's an inflammatory pathology, give a trial of steroids. This is another patient, a young female patient with diminution of vision in the left eye for last 5 days. She's been on ATT for pulmonary TB for last 2 months. The CECT again is suggestive of an active Cox disease. The Mantoux is highly positive. And what you find over here is a choroidal granuloma, and very classically you see these petechial hemorrhages. Again, very classical of a TB granuloma. You also have a granuloma involving the optic nerve head. You have an element of exudative retinal detachment. You see the choroidal granuloma on the OCT. And this patient, of course, has undergone the treatment that we often recommend now is the intravitreal injections of Avastin and moxifloxacin, and you find that there is a beautiful response where the entire choroidal lesion, the optic nerve head lesion, has beautifully dried out. But what this patient now develops is a paradoxical response where the lesion has appeared in a new area, and now this paradoxical response one needs to recognize because this is an immune-mediated response. And therefore, the patient is now treated with IVMP followed by a high dose of oral steroids, and you find that there is a beautiful regression of this paradoxical response. So don't get confused with something that this is an infective pathology but can now present with an immune-mediated response and starts looking like a worsened case. But again, if we had not recognized this entity and not treated with high-dose steroid, the patient would not have responded. So the patient comes back to a vision of 6/6N6 because we've treated the patient with IVMP and oral steroids. Now coming to local steroid therapy, the indications are non-infectious uveitis in adults, pediatric uveitis not responding to systemic therapy, and the contraindications, of course, is pregnancy, diabetes, and psychiatric illness. The side effects, I'm sure we are all well aware of, is a rise of intraocular pressure and, of course, a cataract formation. So this is one of our patients, a 33-year-old male patient with a history of trauma to the left eye. And the vision in the left eye is hand movements and now starts showing an inflammatory response in the right eye, which, of course, cannot be anything else but for a sympathetic ophthalmia. And you see these multiple pinpoint leaks, which are very much seen in the right eye. And you have this exudative detachment again on the OCT, which again is an evidence of sympathetic ophthalmia. And the patient is treated with high-dose steroids and is put on a immunosuppressant in the form of azathioprine, and the patient responds beautifully to the implementation of steroids and to azathioprine and is back to a 6/6N6 vision. This is another young patient of mine being on treatment with ATT and systemic steroids, not responding, having active lesions which are persisting and it's progressing. And here we treat this patient with a local Ozurdex implant, and you see that it has again beautifully responded. So this is another weak age patient, but the problem over here is that she is a pregnant lady, so you cannot opt for any kind of a systemic therapy. And that is why what you need to do is to consider something else. So here we have treated this patient again with an Ozurdex implant, and the patient has beautifully responded because here our hands were tied and we could not use any kind of a systemic therapy. So these are a few questions we need to really question ourselves before starting systemic steroids. When to give? So moderate to severe bilateral inflammation resistant to local therapy, threatening macula and vision, and the optic nerve involvement. What to search for is a systemic association or an underlying infectious etiology where they may be contraindicated. And what to monitor are the systemic side effects. So I'll just conclude by saying that what are the principles to remember for smartly using steroids in uveitis? Assess the type of uveitis. Rule out infections and malignancy as a cause of uveitis. You have to hit hard and you have to hit fast. So induction with full dose of steroids to control inflammation is very important. maintenance with steroids or immunosuppressants for chronic uveitis, use steroids judiciously with monitoring of systemic side effects, early shift to immunosuppressants or local steroid therapy in children is very important, and consider local therapy whenever the systemic steroids are contraindicated, such as diabetes and pregnancy. So thank you so much for your patient listening.
Thank you so much, Dr. Manisha. Sir.
I often tell that the steroid is almost like a mother of all anti-inflammatory treatment. So nobody takes care as good as mother, and it hits, but nobody takes that much care like a steroid. It acts so fast and so beautifully and so quickly, so efficiently in most of the cases. So I would prefer steroid till today, as I started 40 years back, as the initial phase of the treatment, except for some conditions like Behçet's disease or JIA.
Thank you so much, Dr. Manisha.
Thank you
for your presentation. And as there is paucity of time, I would request Dr. Reema to please present her talk on the double-edged sword, what to do and what not to do when starting immunosuppressives in uveitis. Dr. Reema is Professor of Ophthalmology at the prestigious PGIMR Chandigarh. She has 235 guest lectures, 173 publications, and she's been a co-author of a book and 27 chapters in other books. She has received 18 awards. She is the reviewing editor of Ocular Immunology and Inflammations Journal and sub-editor of the Indian Journal of Ophthalmology. May I welcome Dr. Reema to please present her talk.
Very good morning to all of you, and thank you, Dr. Chekita, for having me in your instruction course. Disabled है वो नहीं रहा So the topic given to me is on immunosuppression, but I was highly impressed by Dr. Biswa's statement about the steroids being the mother, because sir said it doesn't, nobody else takes care as much as a mother do. And I would say steroids, like a mother, have an unconditional support. So whenever you have a problem, you go back to steroids. So it's like mother. Whenever you have a problem, she's always there to support you. So wonderfully said, sir. So with this, I move on to the double-edged sword as far as the immunosuppressive therapy is concerned, and what to do and what not to do when we start our patients on immunosuppressive therapy. So first thing is, we have to be very clear about the indications of immunosuppressive therapy in uveitis. And since all of us who are practicing uveitis are by and large clear about it, at times we tend to be overconfident, and this is where we make a mistake. So we have to be very clear, and the indications are whether we are giving immunosuppressive therapy for the steroid responders, patients who are not tolerating steroids in any form. If there is a poor response to systemic steroids in the form of persistent uveitis, the uveitis is not responding well, or there is recurrence of inflammation, or there is paradoxical worsening of uveitis. Third, when the patients in whom systemic steroids are contraindicated, for example, CSR, or uncontrolled diabetes or hypertension. Intolerance to systemic steroids, patient is an old patient, there is risk of osteoporosis, fractures, adverse events with previous steroid therapy, if there is a history like this, and when there is a contraindication to intravitreal dexamethasone implants, where you have uveitis with hypotony, you have CSR, steroid responders in form of high IOP or significant cataract, aphakia or scleral fixated IOLs. Now the second point that we need to consider is pre-existing challenges in uveitis. Of course, when these patients who are enrolled for immunosuppressive therapy, now these eyes have already run an aggressive or a chronic course of uveitis, and we know that they have a limited visual potential despite starting them on immunosuppressive therapy. So Initiation of systemic anti-inflammatory therapy or an antibiotic therapy in uveitis requires only minimal basic workup, like blood sugar, blood pressure. But when we have to start immunosuppressive therapy, it needs a much more elaborate workup. You need to have complete counts. You need to have the biochemistry, the LFT, and the RFTs. The duration, another challenge is the duration for which the immunosuppressive therapy is prescribed is going to be much longer. It's going to be at least 2 to 3 years. It's going to have a lot of financial implications, and patient compliance has to be kept in mind. We have to discuss this with the patient. It's not like steroids where your job is done maybe in a period of 3 to 4 months. It's going to be long term. Adverse effects of immunosuppressive therapy have to be strictly monitored under the supervision of an internist and should not be, I would really say, should not be prescribed by an ophthalmologist alone. We may think of a time in future where we are very confident in prescribing ourselves, but I would not recommend. I work in a center which is a multidisciplinary, so I have that advantage. So despite having that advantage, I have never started any patient on immunosuppressive therapy myself without involving the rheumatologist because I cannot take that risk. So I would recommend the same for those who are in private practice. Don't take it lightly, and I'll show you an example which will be a life learning lesson for all of us. So though rare, these complications can be fatal. So rarity is not the thing that we can enjoy, but fatality is the thing that we need to be really worried about. So coming to my point, the focus of discussion, double-edged sword. So what to do when starting immunosuppressive therapy, and then later on what not to do. So what to do is, you've heard from the previous speakers, rule out an infectious etiology of uveitis. Even if you have a slightest doubt that this could be an infection behind the uveitis, hold on to your immunosuppressive therapy. Patient counseling is a must about why we are starting immunosuppressive therapy, what are the potential adverse effects, what's going to be the cost, especially when you are starting drugs like mycophenolate, and what's going to be duration of the therapy. Because when you're starting, you're telling the patient that I have given up with the conventional treatment like steroids and antibiotics. Now I need to put you on this therapy, and why? It's going to be long. Patient's consent is a must, and you have to ensure patient compliance. Because there are cases, for example, of VKH, where you're starting with IVMP, you're putting them on a tapering dose of steroids, you're starting them on immunosuppression, the patient is doing quite okay at 6 months. But if the compliance is bad regarding immunosuppressive therapy, patient comes back with a very bad recurrence, and then you have to tell the patient that if you leave this drug in between, we are going to go back to basics, and we're going to go back to the cycle of IVMP. So the moment patient hears that, he or she is convinced that I cannot take that risk, because these IVMP and high dose oral steroids, 1 milligram per kg body weight per day, is very difficult to tolerate. So it's better to tell the patient, we'll go back to that, so don't miss these immunosuppressive drugs. Rule out any pre-existing immunosuppressed state, not only by the history, but by the labs as well. Baseline blood tests are mandatory, has to be supervised by an internist or a rheumatologist. Rule out pregnancy and lactation. That holds for every drug that you're starting in ophthalmology. For example, I'll just deviate for a minute. We see a lot of patients of toxoplasmosis, and many of them are young girls and women. And we really don't bother to ask if they are married, they are expecting. And I have seen these errors where we don't ask the history. We start the patient on anti-toxo treatment, and the patient has had to go for abortion. Because when the gynecologist comes to know the patient is on anti-toxo, they advised MTP. So please be careful, rule out pregnancy and lactation. So coming back to immunosuppressive therapy, frequent and regular monitoring with LFTs, CBCs, and RFTs. Now, what not to do? List is small, but very important. Do not give an infectious uveitis. We've covered that. Do not ignore if there is any adverse event reported by the patient, either symptomatically or indicated by the laboratory tests. Even if it is a subtle complaint, please listen to it. Do not prescribe the full dose initially. Unlike steroids, where we start with a full dose, like 1 milligram per kg per day. But immunosuppressants, we start with the lower dose, step it up, and then go to full dose in a few weeks. So we don't start full dose initially. It has to be stepped up very periodically under monitoring. I'll quickly take you through this example. This was a young girl, a 13-year-old, presented with bilateral panuveitis. Choroidal granulomas were confirmed on ICG. You can see she had Cushingoid facies because of prior oral corticosteroid therapy. She was given elsewhere before she came to us. So since she was a 13-year-old girl, we sought our pediatric rheumatology consultation for the cause also and for these Cushingoid effects, because we had to start the patient on steroids. So following the laboratory tests, a diagnosis of presumptive ocular sarcoidosis was made. Oral steroids were started. And because she needed steroid-sparing therapy, methotrexate and azathioprine was started after a normal baseline hemogram. So this is what you're seeing. Her baseline tests were. 2 weeks, her panuveitis resolves, but because we had ordered, our protocol is we get the baseline CBC, RFT, LFT done. We repeat them at 2 weeks. We repeat them again at 2 weeks. And because we are starting initially at 50 milligrams of azathioprine, that is recommended by our rheumatologist. 2 weeks, we monitor the tests. We hike it up to 100 milligrams of azathioprine. Again, we see LFTs, RFTs, and CBC. If normal, we hike it to 150 milligrams per day. And that's the usual full dose that we give, 150 milligrams OD for a normal body weight adult. Now, 2 weeks after starting azathioprine in this child, she complained of complete loss of hair, alopecia totalis, with hyperpigmentation of knuckles. You can see here. And this time the report that she had brought, because we advise it anyways, her hemoglobin, TLC, platelets, you can see, suggestive of pancytopenia. So we immediately referred her to a pediatric rheumatologist. Azathioprine was stopped. Injection GCSF 300 microgram was given subcutaneously for 2 weeks. That's the treatment for it, for neutropenia. Mycophenolate mofetil was added, and NUDT15 mutation study revealed homozygous variant. There was normalization of hemogram at 1 month follow-up. That means another 1 month from the baseline. So these are the serial photographs at 2 weeks, 1 month, 3 months, and then 8 months. And you can see there is complete reversal of alopecia. There was complete reversal of knuckle hyperpigmentation. So azathioprine is a well-tolerated drug. Its side effects are rare, but it can cause the dreaded complication of myelosuppression in genetically predisposed individuals who exhibit mutations in TPMT and NUDT15. It's an early marker of azathioprine-induced myelosuppression. So whenever you see alopecia in any of these patients, please be cautious, hold on, get the test done, take a rheumatologist's opinion. Alopecia usually precedes myelosuppression, so it comes before myelosuppression, but it can also occur simultaneously with myelosuppression. And knuckle pad hyperpigmentation is even rarer, and it's strongly associated with megaloblastic anemia. Both these enzymes influence metabolism of azathioprine. So their any polymorphism then results in accumulation of active 6-mercaptopurine, which gets converted to 6-thioguanine nucleotide metabolites, producing cytotoxic effects. So as a result, in the disruption and the mitotic activity of the actively growing hair, the anagen, more catagen follicles are seen than anagen, leading to hair loss. So while massive hair loss is well recognized, say following azathioprine as a toxicity sign, there is no report of knuckle pad hyperpigmentation as a direct adverse reaction of azathioprine, and this is basically because of megaloblastic anemia, and that has been reported to azathioprine. So we linked this knuckle pad hyperpigmentation to megaloblastic anemia secondary to azathioprine. So I'll not talk about the mechanisms in detail. So GCSF was given because it reverses neutropenia by regulating the neutrophil production in the bone marrow. So this was the treatment in this child. So that's led to the reversal of alopecia and knuckle pad hyperpigmentation.
I would request you to conclude, Dr. Iman.
So
we're out of time.
As per our setting in India, both these tests, the mutations are low, and it's an expensive test. So we don't recommend these testing in all the patients who are started. on azathioprine or any other immunosuppression. So they have to be done as on a case-by-case basis. So to conclude, this kind of fatal toxicity is enough to make us learn even by one example. So I would say that we have to be very careful in starting any form of immunosuppressive drug in our patients, and we have to be alert in recognizing these signs, clinical signs, before the laboratory tests tell us the diagnosis. So it's a double-edged sword. The benefits of immunosuppressive therapy in sight-threatening uveitis justify their use in uveitis, but their adverse effects, though uncommon, can be serious and may prove fatal. Thank you very much.
Thank you so much, Professor Reema. I would now request the next speaker, Dr. Jyotirmay Biswas, to please deliver his talk on where there is a will, there is a way, how to use biological in complex uveitis. Dr. Biswas is an ophthalmologist who is specialized in uveitis. He has done his fellowship in vitreoretinal surgery from Shankar Nethralaya and fellowship in ophthalmic pathology from Doheny Eye Institute, California. He has published 570 articles in PubMed Index journals, 70 chapters in books, and he has presented over 300 papers in national and international conferences. He has had 5 books on uveitis to his credit and 1 book on ophthalmic pathology. He is a member of AIOSG and a fellow of the Indian College of Pathologists. Sir has been ranked 8th in top 2% of Indian researchers in ophthalmology by Stanford. Currently, he is working as Director of Uveitis and Ophthalmic Pathology at Shankar Nethralaya, Chennai. Welcome, sir.
Good morning. Thank you, Chekitan, for giving me this opportunity. After the steroids, immunosuppressive agents, JAK inhibitors, let me talk about a new drug in the horizon. Let me start with a case. This is a 28-year-old male from Chennai, came to my OPD on March 2022. He complained of marked blurring of vision both eyes and received recurrent oral aphthous ulceration, as you see in the picture, and he had also leg ulcer. Was treated elsewhere with the oral steroid, no improvement. And this was the fundus picture of the right and left eye. You can see the vitreous disc is slightly pale, and vision was 660 in the right eye and 6/24 in the left eye. He was given subcutaneous injection of adalimumab once I make a diagnosis of Behçet's disease. And once in 2 weeks, such 8 injections was given, and see it. This before treatment was 660, now the vision has become 6/9. And his oral and leg ulcer got healed. What the patient received was injection adalimumab, a biologic agent, which showed dramatic improvement in this vision-threatening disease. So I'll be talking briefly about a role of biologics in uveitis. What are the biologics First of all, is a biologic response modifier born of recombinant DNA technology. And these block active or bioactive mediators of the immune response. So this can be TNF inhibitors, anti-interleukin, CD20 B-cell directed, co-stimulatory blockade, and interferon, of which TNF inhibitors are more popular. Interceptor is not used in uveitis because it aggravates uveitis. The one which you are more familiar with, adalimumab, which is given subcutaneously, infliximab intravenously, golimumab, and cetrolizumab, which I am not have no experience. Of the anti-interleukins, top popular is tocilizumab, IL-6 inhibitor, which is used in the posterior uveitis, particularly macular edema. And we have got CD20 cell B-directed rituximab, which is used in the necrotizing scleritis or in severe resistant posterior uveitis. So these are the biologics agents. Why use biologics? This is an alternative in inadequate response. Why you have continued your usage of steroid immunosuppressive agents or exhausted. There you have to use that biologic agents, which is a new option. Is the intolerance to conventional immunotherapy and first line of therapy in certain conditions like Behçet's disease, juvenile idiopathic arthritis associated uveitis. What are the indications is that, as I mentioned, bases, GI-associated uveitis, HLA-B27 associated uveitis, particularly when it's associated with the systemic conditions like ankylosing spondylitis, Bloss syndrome, recalcitrant non-infectious uveitis, recalcitrant scleritis. How are they used? Intravenous is infliximab and rituximab, and subcutaneous is adalimumab and golimumab. Adalimumab is quite popular nowadays. So I just share our experience in biologic UV, in uveitis. We are one of the first people started using biologics in our clinics. So I'll talk about adalimumab in non-infectious uveitis. This is a retrospective observational study when we used the disease inactivity was seen in 97.7% cases. If it is a quite nicely selected cases, you can get a very nice result. Disease remission was 74% eyes. Oral steroid stopped completely in 46.2% patients. Dose reduced to 2.5 milligram in 30.8% patient. Vision improved or maintained about 85% cases. Vision worsened about 14% cases. This is due to the cataract or macular changes like epiretinal membrane. Drug discontinuation is the one patient due to financial constraint. He was switched to methotrexate, but later on he has to change to adalimumab again. Relapse was seen in 2 patients. One is the rheumatoid-associated anterior uveitis with intermediate uveitis and GI-associated anterior with intermediate uveitis. No systemic infection or adverse reaction, except now I have got one patient who had got tubercular ascites. Otherwise, none of the patients has systemic infection. This is a before adalimumab therapy of a case, and this is after adalimumab therapy with cataract extraction. So cataract, central band keratopathy, retinal detachment, secondary glaucoma and hypotony was the cause for the less visual outcome. So conclusion is that adalimumab we found quite effective in gaining back the vision, reducing the recurrence and controlling the inflammation. The drug is safe and well tolerated. It has a corticosteroid and immunosuppressive sparing effect. We published a series of basis uveitis, and when you use that biologics or immunosuppressive agents, visual gain is quite high. And this is a case which is a basis disease. Infliximab was used, and there is a complete resolution of inflammation. One can use the golimumab also in treatment of the uveitis. Which we are recently using is the HLA-B27 associated uveitis, anti-TNF inflammation in necrosis alpha agent, anti-tumor necrosis factor alpha agent. Partho has done a great study, and we have found that 14 patients where there is a systemic association like ankylosing spondylitis is quite effective. In case of Bloss syndrome, this is arthritis involving interphalangeal joints, maculopapular dermal rash, and this patient had Buschak's nodules and granulomatous anterior uveitis. It responded elegantly with 2 years follow-up. Ocular lesions subsided and the patient gained back vision. In non-infectious uveitis and scleritis, biologic therapy has been found to be useful. Adalimumab we have used 60% cases. Infliximab is the next choice. Rituximab we have got less experience, and golimumab even less. So another agent is the interleukin-6 inhibitors is tocilizumab in patients with non-infectious uveitis. This is a patient of rheumatoid arthritis, juvenile idiopathic arthritis, associated uveitis with band-shaped keratopathy. She was given methotrexate, infliximab, adalimumab, all become resistant, and subsequently developed huge CME. And we give the tocilizumab injection, and after tocilizumab, the macular edema resolved. Long-term follow-up patients with scleritis after rituximab treatment was also very encouraging. So what are the tests we should do before starting biologics? Complete blood count, ESR, CRP, liver function test, urine routine and microscopy, Mantoux test, quantiferon, Mantoux test, quantiferon TB gold test, chest radiograph, and hepatitis B surface antigen, anti-hepatitis B antibody, anti-hepatitis C antibody. I won't talk about tofacitinib, which has been told by Partho. So biologics have emerged as a new weapon in that armamentarium in the management of non-infectious uveitis and scleritis, works best in Behçet's and GI-associated uveitis, needs more data, needs precautions before starting therapy, not without side effect, and is costly. Thank you very much.
Thank you, sir, for that enlightening talk. And for want of time, I would go straight to our chief instructor, Dr. Chekitan. Vanakkam Chekitan, and that's how we still address ourselves. And he has done his DNB and his fellowship in research and clinical vitreoretinal fellowship from Shankar Nethralaya, Chennai, FRCS. He doesn't only do posterior segment work, he has invaded the anterior segment as well. He has 25 publications and 60 scientific papers and posters and invited faculty at various conferences. He's presently the medical director and head cataract, refractive and retina services at Ishwar Eye Center, Rohtak, Haryana. Dr. Chekitan, please.
Thank you so much, Amitabh. So I'll just rush through my presentation. My topic is trump card using methotrexate to navigate tough uveitis scenarios. This is the brief outline, no financial disclosures. So methotrexate was first used to treat intraocular inflammation in 1963. US FDA approved for treatment of rheumatoid arthritis in 1988. It has two mechanisms of action. So it is the second action, which is the AICR transformylase inhibition that causes the anti-inflammatory effect. The dose is as low as 7.5 milligram, can go to 25 milligram per week, can be given by all routes, per orally, subcutaneous, intramuscular, and intravit. Supplementation is with folic acid, 5 milligram per day. Full efficacy is reached in 6 to 8, rather I would say even up to 12 weeks. Usage tenure is 6 to 24 months at an effective dose. Tapering can be done after 3 to 12 months of therapy. Monitoring is with CBC LFT, preferably done every 6 to 8 weekly. Precise dosing based on the disease type, severity, compliance, and medical and social conditions and complications. Indications and responsiveness, you can see from this particular table that childhood chronic uveitis responds the best to methotrexate, followed by scleritis, then anterior uveitis, then intermediate uveitis, and pan-uveitis is among the lower responders. Very effective in OCP as well. Very effective in sarcoid uveitis. They say with steroids and methotrexate, sarcoid effectively melts away. The most common side effects are gastrointestinal and malaise. And bone marrow suppression follows and increased level of liver enzymes. That is when you have to reduce the dose. When do you add methotrexate? Uveitis, which is not controlled on corticosteroids alone. Maintenance of a suppression of uveitis requiring oral prednisolone more than 10 milligrams. That is the dose which becomes unsafe for a long-term use. So it has to be less than 10 mg if you want to continue steroids for a moderate term. Or patient developing intolerable side effects, as you can see this particular lady developing acne and moon face and brittle bones. Specific disease known to respond poorly to corticosteroids alone, like this fern petal leakage in a case of Behçet's disease. Disease is known to respond particularly well to methotrexate, which is a sarcoid vasculitis. You can see the candle wax drippings. Intolerance to other immunosuppressives like allergy to azathioprine and cyclosporine. Socioeconomic status, it's very pocket-friendly immunosuppressive. I just did a study in which I found out that methotrexate every day cost was rupees 11 per day, compared to azathioprine 155 milligram was 34 rupees per day, and mycophenolate mofetil was around 120 rupees per day. So this seems a very small figure, but if you continue it for 2 years, that is a substantial amount of money. So this is a case, a young boy, 20-year-old, presented with right eye decreased vision since many years, and left eye he was seeing a scotoma since 2 weeks. You can see a choroiditis patch invading the macula from the superior arcade. It is active on autofluorescence and also on fluorescein angiography. Investigations were positive for a ESR which was raised and a MEN2 which was positive. So it was diagnosed as presumed tuberculous serpiginous-like choroiditis, referred to a physician for ATT. After ATT was started, was given IVMP, 1 gram per day for 3 days with systemic steroids 1 milligram per kg, which was continued. However, the uveitis continued to progress. At this point of time, I added a posterior subtenon tricort. But even after that, you can see 3 weeks post all of this, PST, IVMP, systemic steroids, and ATT, it is still progressing, reaching very close to the fovea. At this point of time, we discussed with the internist, and at that point, repeated IVMP, 3 doses, And that is the time there was a sigh of relief and it started responding and healing. You can see the healing age on autofluorescence here. And 6 weeks post that, we added methotrexate, and 6 months down the line, the disease was completely healed. This is another case of a recurrent multifocal choroiditis in a middle-aged female. She was taking steroids for the 3rd time and was on 30 milligram when she presented to us. So after starting methotrexate, 6 months, you can see that the lesions are healing on autofluorescence and color fundus. And we had acquired Optos by then, and you can see the great amount of extra information that the Optos is giving, and a beautiful autofluorescence. This is 11 months post methotrexate, which is a completely healed choroiditis. Methotrexate comes to the rescue in recurrent anterior and pediatric uveitis like HLA-B27 associated uveitis, which is the most frequent specific cause of uveitis in young adults. Mostly presents at acute anterior uveitis, can also present as intermediate and posterior uveitis, has concurrent systemic disease in a majority of patients, typically managed with steroids and cycloplegics, topical. Recurrences are although very common, and sometimes they can present as a fibrinoid reaction. So it's a very bad recurrence sometimes and has a cumulative effect. Methotrexate is the most commonly used systemic agent for treating these, and it has a triple advantage. It prevents recurrences, reduces severity, and addresses systemic disease. Pediatric chronic anterior uveitis is another challenging cases to manage. Uveitis management is challenging as children are usually asymptomatic and have complications right at presentation. Long-term use of topical steroids can cause cataract and glaucoma. Long-term systemic steroids can cause irreversible consequences on the skeletal and immune system. Once a week, methotrexate has become therapeutic agent of choice in children with JIA. In low doses, methotrexate is less toxic than most immunosuppressants, including corticosteroids. In a study, methotrexate therapy reduced topical steroid use from 6 times to 1 time a day, and steroid use from 18 milligrams to 2.8 milligrams a day. So that is a considerable reduction in steroid dosages and considered side effects. A randomized controlled trial comparing methotrexate to mycophenolate shows that 69% of the patients at 6 months were in remission compared to 47% with mycophenolate. Median time to success was, however, the quickest for mycophenolate and the slowest for methotrexate. Methotrexate is more effective and better tolerated than other immunosuppressive agents. Severe posterior or panuveitis is where they respond poorly to methotrexate, and prior use of any other immunosuppressive does not dull its effect. It is a known teratogen, however, so if patient is planning to conceive, at least 3 to 6 months, the patient should be off methotrexate. Intraocular methotrexate has been tried in uveitic macular edema in various conditions. However, it is the short half-life which actually is a demotivating factor. I have also used it in Behçet's disease with limited this thing. So it was the SITE study which proved that the usually commonly used immunosuppressives are safe. They do not cause cancer. And achieving a remission, the highest in these cases was cyclophosphamide, followed by mycophenolate, then methotrexate, and then azathioprine. So the take-home message is methotrexate is moderately effective at controlling moderately active cases of uveitis. It is pocket-friendly, and you should do a good clinical examination and imaging. IM route avoids gastric complications. My starting dose is 10 milligram weekly with escalation, not associated with an increased risk of malignancy. It is a known teratogen. Informed consent is a must for starting all immunosuppressives, and immunomodulation is a long-term commitment. Please educate your patient adequately. Thank you so much.
Thank you. Our time is up. We'll conclude the session. I'd like to congratulate Chekitan for designing such an interesting and informative, innovative instruction course. Thank you all the speakers, and thank you audience for patiently hearing.
Thank you very much.